Hello and welcome to today's webcast, The Mega Rules Clout, How Changes in Pharmacy-Related Services Will Impact You. I'm Jim Berkland, editor of McKnight's Long-Term Care News, and I'll be your moderator. The so-called mega rule for nursing homes, that is, rules for operators that want to participate in federally funded programs such as Medicare and Medicaid, has captured a lot of interest since first splashing down in October. One of the most intriguing subject areas has to do with pharmaceuticals and pharmacy services. Whether you wear the lab coat dispensing meds, conduct med passes on the floor, or have some other caregiving responsibility like administration, you have a big stake in today's webcast. We know that providers who understand the challenges can devise better new strategies that will put them in a stronger position to succeed. That's a big reason we're glad to have Todd King with us today as our featured speaker. Todd received his Doctor of Pharmacy degree 27 years ago and has spent an awful lot of time since then in and around care facilities like yours. We'll hear from Todd in a few moments, but first we have some housekeeping matters to take care of. Today's slides are being presented on an as-is basis and will not be available for download. They have great many takeaways, though, so you want to be ready to take a few notes. If you believe you're having audio problems with this broadcast, please first check the volume control on your machine. We found this is the most common cause of hearing problems on presentations like these. Also, we will have time for a Q&A session at the end of today's presentation. If you have any questions for Todd, please feel free to tap them out and submit them directly to us at any time during this hour, starting now, in fact. Now, about CE. This educational offering has been reviewed by the National Continuing Education Review Service of the National Association of Long-Term Care Administrator Boards. That's NAB to most of us. It has been approved for 1 clock hour. However, you need to stay tuned to this event for its entirety during its original broadcast in order to receive a certificate. We'd also like to note this program is made possible by support from Omnicare, a CVS health company. Please visit its website at www.omnicare.com. But remember, don't interrupt this webcast presentation if you would like to earn the CE credit. Finally, this session will be archived and available on demand shortly after this live broadcast. You can access it again, or others can experience it for the first time by simply going to the registration page to enter this studio. The URL is www.mcknights.com/January 31 webinar. That's all smushed together, January 31 webinar. And you can still do it all at no cost. But as I mentioned, accrediting bodies dictate that CE credit may be given only for attendees at this live broadcast. Now I'd like to tell you a little bit more about today's featured speaker. Todd King is currently the Senior Director of Clinical Services at Omnicare. His responsibilities include managing consultant pharmacists and clinical managers for both the Northeast and Southeast U.S. sectors. Among other accomplishments, he implements clinical programs, manages facility formulary, and provides education to providers and colleagues. Todd is a fellow of the American Society of Consultant Pharmacists and is a certified geriatric pharmacist. He's active in a wide variety of local and national professional organizations, including the North Carolina Healthcare Association and the North Carolina Assisted Living Association. In other words, we're going to get a lot of great info from one of the best informed people out there in this field. Be ready for some fantastic tips. Well, Todd, that brings us to this 700-plus page mega rule. A person could start reading that and get lost in it for days, as I'm sure some of us have. And it's really a lot to take in, but how critical do you think the parts are that touch on pharmacy?
Well, thanks a bunch, Jim. And first of all, I'd like to thank everybody for jumping on the webinar today. And I do, as Jim mentioned, we do have a lot of things to cover. The sections in the mega rule regarding pharmacy services are pretty extensive as far as a review and updating of the state operations manual. So we'll dig into these and move forward and talk about a few of these items as we go through the slides. I think it's an exciting time for all of us to kind of look back at where we've come in the last 20-plus years regarding the pharmacy services to nursing homes and facilities across the country and kind of look forward to where we're going in the future.
Well, that sounds like an excellent jumping off point. So if you're ready, Todd, why don't you take it away?
Thanks, Jim. Well, as I mentioned, good afternoon, everybody, or good morning, wherever you're listening from. we're going to go through some slides today that kind of outline the medication-related changes to the State Operations Manual and the Mega Rule from a pharmacy standpoint. So I think as we go through these, we're going to talk a lot about some of the changes that occurred, some new things that have happened, and then some things kind of indirectly related to pharmacy like antimicrobial stewardship and a couple of other areas as we move along. I'm going to go through the slides today and just kind of touch on specific areas that I think will be important to you moving forward and looking specifically at opportunities for us to make sure that we're providing the highest pharmaceutical care to our residents in our facilities. So on the next slide, we'll touch briefly on the medication-related changes. And I think as most of you are aware, the Mega Rule is going to be implemented in 3 phases. The first phase did go into effect on November the 28th, 2016, the second phase in 2017, and then the third phase in 2019. I think one of the things to kind of remember is when we went through the process of looking at specifically these rules prior to them being published, there was an open comment period. And many providers across the country, pharmacy providers, long-term care providers, provided input on the proposed changes in the Mega Rule. And I think CMS received about 10,000 comments around some of the specific areas. Most companies that did provide comments did get feedback on the initial document as it was presented. So a lot of the things that you're going to see today were things that were provided feedback from pharmacy providers and other types of providers around the medication-related issues. So let's talk a little bit about some of the things that have happened recently. And when you look through the slides that we're going to kind of go through, it's important to remember that the State Operations Manual had not been updated for quite some time. This was a document that at its core was about 20 years old. We all know there was an update in 2006, but the document did need pretty much an overhaul. So a lot of the things that you'll see as we go through these slides just talks a little bit about where CMS was bringing up to date the policies and procedures around standards of practice and standards of care in our current processes. So I'll give you a couple of examples there. One of the things that we wanted to do was to update the unnecessary drug guidelines, and that was a standard that was already in the State Operations Manual Appendix PP, along with med-error expectations, etc. Other areas, such as reviewing the medical chart record or performing the drug regimen review, were areas that were considered standards of practice in consultant pharmacy, but also we did add some new areas in there that we'll talk about in just a few minutes. So at the end statement there, some of the things that are considered new were actually really standards of practice in our pharmacy setting. So let's talk about for a couple minutes about what's new. And in phase 1, these are kind of the bullet points that we'll talk about as we go through these slides. Discharge medication reconciliation, definition of a psychotropic drug, irregularities related to changes, facility policies and procedures around the monthly drug regimen review. And as we move into phase 2, we'll talk a little bit about the monthly review of the medical record, psychotropic drug recommendations on PRN medications, and then as everybody is interested and heard about, phase 2 and 3 with antimicrobial stewardship and some of the things that will be available there. So real quickly on the next slide, one of the things that you'll specifically see is med reconciliation. It's important to note that each facility now effective November the 28th will be required to produce a discharge summary that includes medication reconciliation of pre- and post-discharge medications, both prescribed and over-the-counter drugs. And in this statement here, I have listed that CMS does define that process as identifying the most accurate list of all medications that the patient's taking, including the name, dose, and frequency. Many facilities are developing policies and procedures around this and providing med reconciliation at discharge. I do think that this process is kind of setting us up to move forward with some of the medication reconciliation items that we've been discussing for a number of years, doing med reconciliation at admission, doing med reconciliation through the acute care stay into the post-acute care stay. So I think CMS is kind of wanting us to move in that direction, because we all know that a lot of the issues that happen in transitions of care that cause issues are medication related. So it is a good opportunity for us to look at moving forward with med reconciliation in our facilities. The next slide just talks a little bit about the definition of a psychotropic drug. And to be honest with everyone on the phone, when we first saw the initial comments that CMS had produced around redefining a psychotropic medication, it was a little bit concerning. Initially, CMS actually proposed that we have to include certain medications that have central nervous system side effects like opioid analgesics, Parkinson's drugs, etc. Those of us on the clinical side did have a concern about that, because historically those are medications that we would traditionally titrate to a dose, find that effective dose, and maintain the patient on that dose. So there were several comments that were made around this situation, and definitely does allow us for some specific recommendations. So at the end, CMS did come back and say that a psychoactive drug is any drug that affects brain activities associated with mental processes and behavior. Now, from a clinician, that does kind of give us a little bit of subjectivity on that interpretation. So most of us are really anxiously awaiting the interpretive guidelines for this document that hopefully will be out soon. We don't have a specific time frame on that, but I do think once those interpretive guidelines come out, we'll have a better idea on what CMS is going to look for around these specific medications. In the definition, it is important to remember that they did include the typical 4 classes of drugs that we're used to as being defined as psychotropic medications, and that's the antipsychotics, the anti-anxieties, the antidepressants, and the sedative hypnotics. Let's face it, we've done a great job as an industry in reducing antipsychotics over the last 5 years. And I think this will be a time where CMS and state surveyors and federal agencies, I think, start looking at other types of medications, specifically the anti-anxiety drugs and the sedative hypnotics. So going forward, I think it's a good opportunity for us to continue to focus on the antipsychotics, but now move into some of these other categories to look at opportunities to make sure that residents are taking the most appropriate dose, the most effective dose, and when the drug is no longer needed, making sure that it's appropriately reviewed. The next slide kind of moves into a little bit of information around the medication regimen review. And these are kind of some of the changes that have occurred that I think will have a little bit of an impact on the facilities immediately. And one of the things that CMS did was kind of clarify the definition of an irregularity. As a pharmacist, I'm not the biggest fan of that term. I think it would be nice to have a different term, but we did get clarification, and this is a term that we had known the definition of an irregularity. It's just CMS kind of wrote it in the state operations manual the way that we expected them to. And an irregularity includes, but not limited to, any drug that meets the unnecessary drug criteria. And most of you remember back to F329 that an unnecessary drug could be any drug that's used at an excessive duration, at an excessive dose, without adequate monitoring, or in the presence of adverse consequences. So if you think about it, that could be just about any medication out there that we see. One of the changes that CMS did institute is in the second paragraph of this slide, and they did put in the document that the physician's or the facility's medical director must now be informed of the facility's drug regimen review in a separate report. So I think historically what we did in long-term care facilities is the pharmacy would send the recommendations to the attending physician and the director of nursing for their review. CMS has now said that the medical director must get a copy of those recommendations also. So there's definitely something that I think is important for us to remember as facilities. You should have a policy and procedure around having your medical director make sure that we're going to be able to review that report and see that report. The other thing that is important to remember is the last bullet there. And now CMS did put in here that the attending physician must document in the resident's medical the record that the identified irregularity has been reviewed and what, if any, changes will be taken. That's a little bit different updating process than what we've seen in the past. Basically now it's just asking the physician to document his or her rationale in the resident's medical record. Sometimes the pharmacy reports in the past were actually kept in a separate file system or a separate process for the director of nursing to provide to the surveyors. But I think as we've moved forward with electronic health records and other types of electronic systems, CMS is looking for us to move those recommendations into those permanent records. Slide 11 does next talk about briefly the monthly drug regimen review facility policies and procedures. The facilities must develop and maintain policies and procedures for the drug review that minimally include time frames for different steps in the MRR process. And one that is a little bit new is the steps the pharmacist must take when an irregularity requires urgent action to protect the resident. One of the things that's important that's important to remember is that in certain situations we deal with very sick patients who are on a lot of medications and have a lot of diagnoses and conditions. And with the number of meds that continue to come out and come to the market, there are times when there are critical or urgent issues that happen around medications. And CMS is wanting the facilities to have policies and procedures around those critical issues so they can be addressed in a timely manner. We'll talk about that a little bit on the next slide. So this slide just talks a little bit about some specifics that were documented in the new mega rule around medication regimen review. The consultant pharmacist med review is part of the resident's permanent health record. So in other words, those recommendations, their comments, any documentation that the consultant pharmacist provides should be placed in the permanent health record. Consultant pharmacists require access to the entire health record to do an effective medication regimen review. The consultant pharmacist must have access to the entire health record. This is just some updates that CMS put in there because they were never actually in the manual. Consultant pharmacists have been reviewing the whole entire record for a number of years. The facility should assure that the attending physician, the director of nursing, and the medical director, as I mentioned a few minutes ago, should receive copies of the medication regimen review. As we mentioned, the medication regimen review is part of the resident's permanent health record. The attending physician's response to recommendations should be part of the permanent health record. You guys see where CMS is going on this. They really want our processes to be documented in that permanent record. And then last bullet, and this is something that's been in the State Operations Manual for quite some time. It's just, once again, they have put it in writing. This has always been our intention, is if the attending physician does not respond to the consultant pharmacist's recommendation, those irregularities should be referred to the medical director. Personally, I think CMS is actually, by giving the medical director a copy of that report and then also noting that an escalation process would be involved in the facility, is putting a little bit more responsibility towards the medical director and making them more accountable for the overall medical care in the facility. Next slide just talks about a couple other medication regimen review comments, and this actually deals with the urgent medication irregularity. As I mentioned earlier, one of the things that can happen in our facilities is when a significant issue arises and how the consultant pharmacist should handle that and move forward with having that recommendation or irregularity resolved. Historically, and I know as myself and a lot of my colleagues, not just the folks that I work closely with, the consultant pharmacists all over the country, their dedication to the care of the elderly is significant. And those consultant pharmacists, that when they identify something that is significant, they take the steps to communicate that directly with the facility. And in cases where the attending physician needs to be followed up on, it's definitely an area that they'll participate in. If an irregularity does not require urgent action, then there's definitely a process that the facility should have in place to make sure that these recommendations are followed up on in a timely manner. This has been documented in the state operations manual in the past. It's just now defined a little bit more specifically in that there should be specific time frames when the drug regimen review is completed. Slide 14 just talks a little bit more about some of the time frames. And once again, if you look at this slide, these are suggested time frames. These are not, this specific slide is not actually in the state operations manual, but these are just some things that when we go through and teach about this new rule, it's important that the consultant pharmacist and the facility should have some policies and procedures in place to address these types of items when they come up. So urgent irregularities. Personally, I think it's a great idea that the consultant pharmacist solve these issues before he or she leaves the facility for that day. In some situations, there may not be access to an attending physician, or the attending physician may not be available. At that time, it should be escalated to the medical director and for him or her to act on that irregularity. One of the things that we've already seen with some of the new survey processes around the mega rule is facilities being looked at to make sure that they have that process in place for timely follow-up on the pharmacy recommendations. There's really not a defined time frame, but I think it's important as medications become more complicated and we change the type of residents that are in our facilities, it is important to make sure that those recommendations are acted on in a timely manner. We recommend, and some of the things that you see other in our industry do, is that the report should be submitted to the facility within 72 hours and completed within that time frame to make sure that the urgent requests or non-urgent requests are handled in a timely manner. So just to shift gears now for a couple other slides as we go through, I like to put things in these presentations just to make sure that people see when areas are kind of changed in the specific regulations. I did include a slide here on self-administration of medications. I think everybody's aware that there have been comments around self-administration of medications in the state operations manual for quite some time. But there were a couple wording changes in this section, and anytime there is an update, it's important and prudent to always go back and look at your internal policies and procedures. So just as a reminder, I just threw this in here just to make sure that when you go back to your facility and you go and start looking at your internal policies, that you make sure you look at self-administration, because self-administration should be assessed on the determination of the resident's ability to understand and self-administer their drugs. And it must be evaluated on and make sure that the resident is safe, it's clinically appropriate, it's based on the resident's functionality, and also their health condition. And as we all know that self-administrations, when a resident self-administers, it should be reevaluated periodically and make sure that they're still capable of doing that process. So for the next few minutes, we're going to shift gears and talk about one of the things that's not directly related to pharmacy, but I think is important from a pharmacy standpoint because we'll have a significant role in it. And that's the establishment of the Infection Prevention and Control Program. CMS is pushing forward, as I think everybody's aware, to make sure that antimicrobial use in long-term care facilities is as appropriate as possible. And they are starting out with requiring facilities to develop and implement this Infection and Prevention Control Program. CMS has said that a facility must establish and maintain this program, and it includes several elements. And I've listed some on the slide here. And as we talk and as this system grows with infection control and antimicrobial stewardship, some of these may change and some of them may get more important than others. But we really need to make sure that we're identifying, controlling, preventing, investigating, and reporting on antimicrobial use in infectious processes. And the other thing that we need to make sure is that we're educating our staff, our residents, our volunteers in our facilities. And one that's not on here, but is probably one of the most important, is educating our families. Because I think everybody's aware and has had experiences in the past of where a family member sometimes will think that their loved one needs an antimicrobial therapy or an antibiotic therapy because of their symptomology. And lots of times that's one of the areas that leads to challenges around the use of these drugs in long-term care facilities. And let's face it, if you guys, everybody that's been following the lay press out there over the last year, there's really been some very not flattering articles around the use of antibiotics in long-term care facilities. So CMS is going to push for us to establish these committees, and then over the next 2 phases of the mega rule implementation, there'll be significant areas where the facility will have to participate and ramp up their monitoring of antimicrobials and their use. So why do we need antimicrobial stewardship? I think most of us that have been in this business a while have really seen the ebbs and flows of how antibiotics have been used in long-term care facilities. And when antimicrobials are used indiscriminately without targeting specific organisms, or they're given at prolonged durations or high doses, we all know that that leads to resistance, antimicrobial resistance. And that is something that we really need to try to work on to prevent progressing further, because let's be honest, the antimicrobials that are on the market right now and the medications that are out there, the organisms are mutating and developing resistance at a quicker pace than we can develop new drugs. And on the slide here, I've listed you a couple of examples that, these organisms will probably, for the nurses that are on the phone, will probably ring in their ears very, very familiar, but methicillin-resistant staph, or MRSA, is an infection that, 10 to 15 years ago was not very common in nursing homes, but now it's fairly prevalent, and it's actually fairly prevalent in a colonized manner in a lot of patients and a lot of staff members in long-term care facilities. Vancomycin-resistant enterococcus is another organism that has developed over the years as one that definitely causes problems in our facilities and causes problems with the continued resistance of antimicrobials. So as we look forward, I think it's important to remember that CMS is going to want us to develop policies and procedures around this. Most of the things that they talked about in the original release of the mega rules centered around the recommendations from the CDC, or the Centers for Disease Control. So I think that's a good place for all of us to start, is to go in and look at the many things that the CDC has to offer on appropriate antimicrobial use and antimicrobial stewardship. So the next slide just talks about what can long-term care facilities do around antimicrobial stewardship. And one, and at the beginning, is start an infection control team. Many of you probably already have this in place, and I think what's going to happen in the future is CMS and the CDC are going to kind of guide us on a path that we want to move forward with as far as managing antimicrobial use. But if you look at this slide, the CDC believes that the key antimicrobial stewardship leaders in the facility are the medical director, the director of nursing, and the consultant pharmacist. There will need to be a specific involvement from the physicians in this committee, because they are the ones that write the orders for the drugs. They're the ones that need to understand the antimicrobial use. And one thing I want to stress here is in the next kind of bullet. Each nursing home should individualize the selection for this team and utilize their staff that they feel are best appropriate. There's really not going to be a cookie-cutter methodology for this infection control team, because every facility is different. And I think we are seeing some basic policies and procedures, but it is important to remember that the organisms and the drugs that are used in each facility are individualized. So we're going to have to be specific to every building and make sure that we do look at the specific things that are happening in their specific facility. Second thing is to identify patterns. Track infections, antibiotic prescribing patterns, duration of use, cost, and outcomes, at least on a monthly basis. When you look at the things that are going to be real important around antimicrobial stewardship, the key things are making sure, as I mentioned earlier, that we avoid resistance and make sure that we are using the drugs appropriately. We've already seen in some areas some mock surveys and also some volunteer surveys where CMS has come in and the regulatory bodies have come in and done some mock surveys around infection control and the things that are being done in facilities. And we've gotten a lot of feedback on where specific areas of improvement and things that can be moved forward would be more appropriate in a better situation. The last bullet, number 3, just talks a little bit about streamlining empiric antimicrobial orders. This is a process that we feel is appropriate and something that CMS is going to look for us to do in the future. And when you look at standards of practice around empiric antibiotic therapy, and keep in mind empiric therapy is the prescribing of an antibiotic based on symptomology without actually results of cultures and sensitivities. And believe me, there's a lot of different clinical beliefs out there on how empiric therapy should be used. But one of the things that is important is if empiric therapy is used, it's usually prudent to look at a narrow spectrum antibiotic once the culture and sensitivities have returned. So that way you actually take the broad spectrum and narrow it down to a lower spectrum antibiotic that actually kills the infection but also avoids the opportunity for resistance. So basically what we're going to see down the road is we think that CMS is going to push us to make sure that we have committees looking at all aspects of appropriate antimicrobial use. And I think it's going to be an area where tracking the infection, looking at the specific infection, and then also see where we need to go as far as educating our prescribers and continuing to educate our facilities and staff members. Now, let's face it. I mean, one of the things that's a common theme in infection control and antimicrobial stewardship is it's just not about the drugs. It's also about the key thing is preventing the infections. So preventing the infection is something that we'll be working for diligently in the facilities to make sure that, first of all, they don't even happen. And once they do happen, making sure that we're using the appropriate medication and using it for the right amount of time or duration of therapy. So what can we do now? I think from an antimicrobial stewardship standpoint and looking at the process that CMS wants us to go through, it's important to kind of look at some very basic items. So I put this slide in here just because I thought it would be a good jumping off point for some of us just to kind of go through and look at some very basic things. And this is a slide that was kind of created out of the fact of what we've seen that the CDC and what CMS is interested in now. This is very basic stuff, but a correct antibiotic order includes the name of the drug, the strength, the dose, the route, the frequency, the indication for use. We are going to be required to have that indication on each order, on each antimicrobial order, and have a stop date. One of the things that is the most common issue with resistance is giving an antimicrobial too long for a specific infection. So making sure that that order has a stop date prior to it even being sent to the pharmacy to be filled. So is it 10 days? Is it 7 days? Is it 3 days? It needs to be very clear. Because we know out there that there are standards of practice around the treating of specific organisms like urinary tract infections and upper respiratory tract infections, etc. CMS is also going to look at any monitoring that may be required, such as vancomycin levels when you're doing specific medications. And one that is very important, and I think all of us from a clinical standpoint remember that most antimicrobial therapies do alter the metabolism of warfarin or Coumadin and can cause difficulties and changes in bleeding time for patients who are on that medication. So it's important for us to have policies and procedures around the use of that medication, specifically when it's given with antibiotics. And I think most facilities do have that in place, but it's a good policy to kind of go back and review with your pharmacy on what their policy is and what your policy is. And then up in the top right-hand corner, don't forget about allergies. It's always, in our current treatment modalities and the current processes that we have in long-term care facilities, we're pushed to get antimicrobials started as quick as possible. And most long-term care facilities, skilled buildings have emergency supplies of medications. So it's a common practice when the doctor writes that order for the antimicrobial to get it out of the stat box and get it started right then. Please make sure you've got a policy that your nurses check for allergies prior to pulling that drug out of the kit. A pharmacy computer system is going to screen for those allergies. But if the nurse is taking the drug specifically out of the kit, we need to make sure that he or she checks the allergies, because the last thing you want to do is give an antibiotic that a resident is allergic to, and now they've got an allergic reaction and also an infection, and they're not in a good place at that point. So these are some things in the slide here that we can do just right off the bat that will be very easy for us to be in compliance for. So I'm going to shift gears one more time on the last couple slides here and talk about a few things that are coming in 2017. After all, it's amazing that we're in the last day of the first month of 2017, and November the 28th will be here in very short order. So one of the things that you're going to find that I think is pretty significant is the second column there around psychoactive drugs. Being implemented at the end of this year, CMS did put in the mega rule, and I'll tell you, initially when we saw the mega rule, there was a recommendation around the use of PRN psychotropic drugs, and the time frame was a very short time frame around when these medications should be used. We did actually go out and solicit CMS to extend that time period, but what they came back with is that PRN psychoactive medication should be limited to 14 days of therapy. And then specifically around PRN antipsychotics, they may be renewed only with a prescriber evaluation. So in other words, once that 14 days is up, and we need to see what the interpretive guidelines say around this, but there will need to be some type of prescriber evaluation at that point. PRN antipsychotics really should not be used unless there's an acute situation. That's kind of what the standard of practice is for those medications. So this is one that's probably going to be effective for our residents and is going to be an area where we will see a reduction in the use of PRN drugs. Now, of course, with the antipsychotic initiative that we've had in place for the last 5 years, the PRN use of antipsychotics have decreased dramatically over that time period. So personally, I don't think the impact of this one's going to be as significant as the next section, where it does say that other psychotropic PRN medications may be written for a longer duration with adequate prescriber documentation. So once again, this is an area where we're talking about drugs like lorazepam and zolpidem being a sleeping medication, where those drugs, and we need to, as I said, see the interpretive guidelines, will be only used for a 14-day period, and then there'll have to be another assessment. I did this presentation for a group of nurses the other day, and one of the facilities spoke up and said that this is a policy that they already have. They're reevaluating PRN drugs every 14 days and to see whether or not they're to be continued. That's a group or a facility that's way ahead of the game, and I think that's going to be some type of procedure that we'll all be looking at towards the end of this year. One of the things, too, to keep in mind is this is a great opportunity to kind of start talking to your physicians about the potential of this rule, because the doctors are going to be the ones that are going to be responsible for writing those orders, so they'll need to be prepared at this time also. One of my fears, and this was something that we expressed in the comment period that we were given, is that if you limit the use of PRN drugs, sometimes those PRN drugs are moved to routine medications, and that's just something we really can't happen. We need to manage the use of these drugs around the PRN limitations. Lastly, in the last bullet for 2017 around antimicrobial stewardship, we talked a lot about this in the last few minutes, but in 2017, the facilities must have an antimicrobial stewardship program that includes antibiotic use protocols. Some of you are probably aware that there's a lot of protocols out there and stepwise approaches to the treatment of certain types of infectious processes like UTIs and upper respiratory and C. diff and all that type of things. Systems to monitor antibiotic use. a designation of one or more infection preventionists in the facility that must work at least part-time at the facility. This is going to be a big step forward for all of us, because this will be a key person that will help manage the overall use of antimicrobials and monitor them in processes moving forward. And then naturally, influenza and pneumococcal vaccine requirements will continue. For those of you who are not aware, and this is just right off the press, but the CDC did release their influenza update today. So those of you who are in areas where there are outbreaks, it would be prudent to kind of go back and look at that and see where things are progressing with our flu season this year. But that's just kind of an aside. So let's move forward just to 2019, and for some of us that seems like a long ways away, but I just like to throw it in here just because as we start planning and moving forward, just to kind of give some foresight on what we're going to see around quality assurance and performance improvement programs. A lot of you are probably already working on your QAPI programs, but one of the things that I just wanted to mention from a pharmacy standpoint, that your performance improvement activities, if you look at the middle bullet there, one of the things that in 2019 we will be tracking is medical errors and adverse events secondary to medications. And I think it's an important topic, and it's one that we do a lot of monitoring and a lot of assessment already in our facilities. The QAPI program is going to require us to put this in a format to where we regularly review it and analyze data from the drug regimen review. So I think it's a great opportunity for us to kind of go ahead and look down the road and start looking at some of the specifics around ways that we can track and review and analyze adverse events. One of the things that will happen is the IMPACT Act, which maybe we'll have a webinar next year when the IMPACT Act comes out. The IMPACT Act is going to be one that shows and requires us to report around medications, potential serious adverse events to the prescriber. And there'll be more information to come out on that as we move forward. But the QAPI programs are one of the pharmacy-related items that will be available or required in 2019. So just in summary, I kind of wanted to go through put a summary bullet slide in here just to kind of update us on what we've talked about in the last 43 minutes or so. But the items that were effective in November 28/16, as we've talked about, discharge, med reconciliation. One of the key points is the medical director receiving all consultant pharmacy irregularity reports. It's a great time right now, early in the year, to talk to your doctors about what's going to happen, what they need to do with this process, etc. Physician drug regimen review responses must be documented in the medical record. Facilities must develop and maintain policies around DRR, and then the implementation of the Infection Control and Prevention Committee. And then this year at the end of 17, to me, the PRN psychotropic drug one is going to be a key implementation process for us in long-term care facilities. And then also the antimicrobial stewardship program will be progressing as we move forward. And then in 19, the QAPI programs, as we just touched on. So in conclusion, before I send it back over to you, Jim, just a couple quick comments. I think, from a pharmacy standpoint, a lot of things that we're seeing in the mega rule are updates on what are considered standard of practice in our industry. There are some new things out there. There are some changes that we'll have to make in our processes. But overall, when we're looking forward in 2017 and 18 and 19 around the opportunities for implementation, there's a great opportunity for consultant pharmacists to interact with the facilities around their infection control procedures, around antimicrobial stewardship, and participating in QAPI programs. The key things today are for us to make sure that we've got our drug regimen review and medication regimen review processes in place, that we're following up on the recommendations in a timely manner, that documentation is going to the permanent health record, and making sure that we're following those procedures that CMS has outlined. Because let's be honest, the stuff we talked about were basically just very kind of low-hanging fruit, just making sure that we've got a process to communicate to the medical director, et cetera. So if we can all comply with those things, we all should do well in the future. And so thanks again for your time. I'm going to turn this back over to Jim. Looking forward to answering some questions if you guys have questions out there. And Jim, I'll turn it back to you.
Well, thank you very much, Todd. That was fantastic, and it really frames the issues wonderfully. So much going on out there, but this is really, folks, this was really procedurally going right through, telling you so much that we need to know. We would like to get to some questions before we close today, so I want to remind everybody, as we give Todd a chance to catch his breath there, that you can tap in your questions. We've seen them coming across. If we have some great big themes we don't get to, we'll try to, during this session, we'll try to get to them, get back to you after it. So please send in any questions you have now. And Todd, we have to ask that, we've had a number of questions from people coming in. Must the attending prescribe? Can an extender do something? That type of thing. Can you help us out on that?
So, yes, just a couple things real quick. From a physician assistant, nurse practitioner standpoint, those are state regulated. So certain states have regulations where their prescriber processes can be implemented, et cetera. One of the things that I've already seen a little bit of confusion on, that's why I want to caution everybody, is the comment in the regulation says that the medical director should be provided a copy of the report. It doesn't say what he or she should do with it. So at this point, as I mentioned earlier, we are kind of waiting on the interpretive guidelines to see exactly what CMS is planning. This is just my personal interpretation, would be, that the medical director oversees the responsibilities and care of the facility. So if there's an opportunity for him or her to kind of go through that report and see trends or see issues that are not repeatedly addressed, then that might be an opportunity for them to have a peer-to-peer conversation, which is very impactful. And I think that's why, to me, this is kind of a good route for CMS to go, is to involve that medical director in this process. The other situation is simply where if a pharmacy report is not being acted upon, that's another opportunity for that medical director to do a peer-to-peer conversation. Okay. Is that kind of what you're looking for, Jim?
I believe so. The other thing that we've got a variety of questions coming circling around the medication regimen review. Can you maybe jump back on some of what you maybe already addressed a little bit, but clarifying a little bit how that has to be handled? There are a lot of curiosities. Does it have to be this way? Does it have to be that way?
Yeah, I think, when CMS has updated the mega rule with the comments around medication regimen review, they're looking at moving the reports to a standardized place, and that's the patient's permanent medical record. As I mentioned earlier, and there's probably DONs on the phone out there that, have a separate file folder where they keep their pharmacy recommendations and that type of thing. That's kind of a process that we adhered to for years, because historically the surveyors would come in and say, I need to see your pharmacy recommendations. Well, CMS is now moving those into the permanent medical record, and I think that's basically to kind of move us into the century of electronic health records. And that's where we're moving, and, doing away with the paper and those types of things will actually help us, and it'll direct those recommendations to the specific resident. So that's the key thing in my standpoint. The other thing I think is important is from a medication regimen review standpoint, is handling recommendations based on their clinical acuity. As we mentioned, there's a couple things in there where if a patient has an issue that is clinically significant, how that process is moved forward and how it's resolved. I think it's real important for us to have procedures around that, because if you think about it, the rule specifically talks about urgent issues, and that's another area that's kind of open to interpretation. Because clinically, as a clinical pharmacist, I may see something that is something that I might not consider urgent, whereas somebody else might, or vice versa. So there is some subjectivity there, and as you guys know, anytime there's subjectivity, that leads to conversations, and we need to make sure we're followed and make sure we've got policies and procedures to validate why we're doing things.
Okay, great. We're going to try to get to as many as we can here. A couple more coming in. They're rolling in. Thanks, people. Ellen writes in, how will the use of antipsychotic drugs in hospice patients be affected?
Great question. This is one that comes up a lot. And I think, Ellen, I would say that we didn't see a lot of changes around the use of antipsychotics. And in hospice patients, the thought process has always been that, at least in my opinion, is that those medications we should look at them in hospice patients just because if the dose is inappropriate or the patient's sedated or that type of thing. But generally the hospice patients are, in my opinion, not required to have those gradual dose reductions and that type of thing. Plus, at end-of-life care, if it's true end-of-life care, we're generally using that medication for some agitated episodes or those types of things that are maybe PRN would be appropriate. But once again, it's hard. You have to look specifically at the patient. But generally, as a rule of thumb, they should not be required to do the things that we see historically.
Okay, now this one, don't know how deep this will go, but just get a few words perhaps, because it is a curiosity a lot of people out there have, I think. Dana's asking, will the new administration's rollback of regulations and regulatory actions have any impact on these new directives from CMS? What's your quick thought on that?
My quick thought is yes. No, I think what's going to happen, the mega rule went into place at the end of the year. So right now they are in place. I do think for 2017, any new rules that come out will be subject to some very specific criteria that the new administration has put forward.
Right, and it's been delayed a little bit. I can tell folks we've been monitoring the news that the confirmation hearings for Price and HHS have been put off today because of snafu, who's attending and who's not. So that could be up in the air for a while. So let's get back to some core here. Todd, do you recommend facilities track vaccines on a broad scale? For example, facility level rather than just the medical chart. I ask because often it's difficult to assist facilities in tracking this from pharmacy records alone.
So, yes, I think they should be monitoring it from a facility level just because each resident should have a specific tailored vaccine program. And you're right, it's hard to pick it out of the specific chart. With electronic health records, though, I think we can make that a lot easier just because there's ways to report from those systems to provide us information that, we historically would have to go chart to chart. So I think you should monitor it at a facility level also. Okay,
great. A real quick one on this, then we'll go to some final thoughts. Is CMS defining an infection preventionist via certifications or some other way, or will the community designate the person without guidance from CMS? That's from Karen.
Yeah, Karen, and that's one that's come up quite a bit. I do think when we see the interpretive guidelines around the antimicrobial stewardship requirements, there will be some specific requirements outlined for the infection preventionist. I think it'll be someone that is trained in infection control, et cetera. There'll be some documentation around that. Whether or not it's a certification is kind of unclear right now, but I will tell you that at least personally, I think those certifications are going to carry a lot of weight when you have a survey or when you have monitoring or reviewing of your program. But yes, I do think that there will be some criteria that's listed for the infection preventionist in the upcoming interpretive guidelines and the implementation in Phase 2 that we talked about.
Okay, now here's the toughest question of the day, and it comes from me, because unfortunately we're getting close to the end of the time, and you've had so many great takeaways. When the folks click out of this presentation in a few minutes, what is the one big takeaway you really need to impress, or one or two? Let me give you a minute to ask that, or answer that.
Yeah, I think just going back to my summary comments, for Phase 1, in the mega rule, I think we need to focus on our drug regimen review, medication regimen review, and as an older pharmacist, I use those two interchangeably, but medication regimen review processes. Make sure we've got those in place, make sure they're tight, and the DON is monitoring those, your medical director is engaged, and your attending physicians are aware of these changes. And then secondly, from a clinical standpoint, I think antimicrobial stewardship and this infection control committee is going to be a huge part of us going forward. CMS has already said that it's going to be the most costly aspect of the mega rule for facilities to implement. And I really think it's a great opportunity for us to show an impact going forward on things like reducing hospitalizations and providing care to our residents while they're in the facilities, et cetera. So, as we move forward in the health process that we're doing, reducing rehospitalizations is going to be a significant issue in the near future. And this is just a first step for us as long-term care facilities, at least in my opinion, to take a big step forward into helping with that process. Now, there's all kinds of things that cause rehospitalizations, med errors, and all that kind of stuff, but this is a real good jumping-off point, at least in my opinion.
Well, fantastic. And you say in your opinion, well, your opinion counts for an awful lot, as we've learned today. Well, everybody, we certainly hope you've enjoyed today's webcast. Remember that this session will be available shortly at www.mcknights.com/January31webinar. We just must give our special thanks to Todd King for taking time for us today to frame the issues in such an understandable way, one that's really going to help a lot of providers. And we'd also like to thank our session sponsor, Omnicare. Check it out at www.omnicare.com. And we have to thank you, the listeners. You've just really, really made this a big success by putting in so many questions. This is really going to lead to a better understanding of all these important topics. So once again, thank you for tuning in. This is Jim Berkland for McKnight's, hoping you have a great week.